very much.
Thank you. So thank you for the people who have attended the session. One of my instructors, Dr. Sharon, is currently in another IC. But I have my other esteemed co-instructors, Dr. Pooja, Dr. Diva will be joining us. So I'll be speaking on topography and biomechanics. Refractive surgery is obviously undergone a paradigm shift. A lot of parameters, a lot of indices, a lot of tools and devices. And this is a way to just simplify our understanding on, whether we are moving in from topographers, we're going into biomechanics. We also will be dealing a little bit on, our ultrastructural imaging, which is the polarization sensitive OCT. And of course, epithelium is invariably a masquerader and, can sometimes hide a lot of things which we can miss. And therefore, epithelial mapping in our current refractive practice is something which is very important. So I'll be speaking on power of indices. Not too extensive on terms of basics, but I'm sure maybe we can have a show of hands of the people who are here. How many of you have any topographers with you at your center, and what topographer do you have? Sorry? Pentacam? Serious, okay, fine. So majority of the devices now are, Scheimpflug based, whether it is the Pentacam, whether it is the Galilei, whether it is the Cirrus. We've obviously moved across from the slit scanning because, posterior cornea and posterior corneal curvature and aspects of the posterior cornea is something which we don't understand the importance now, but whether it's, suspicious cases, early ectasias, understanding the posterior cornea is something very important. Therefore, the workhorses, I think majority of the places have either a Pentacam or either a Cirrus. And it's important to understand that, there are a set of indices and parameters in each one of it. And what, generally tends to get us confused is the fact that there's so many set of indices, what do we exactly look at? And, there are cases where you see seemingly normal topographies. I don't want to go into basics. You see a FOMAP, the pachymetry is good, not too much of, not significant posterior elevation. But again, you suddenly see the bad D, and many of these parameters are either in the yellow or red. That is where I'm trying to highlight is that never take anything at its, using color codes or at its face value. It's important to look and segregate as to what these parameters are. I'll be speaking a little bit more about it as we move ahead. But when you're talking about, bad D, there are certain errors or there are aspects which sometimes can get erroneous if you're looking at, I spoke about this being, well, it looks normal. But if you look at, the difference between the standard and the enhanced best fit sphere, there seems to be certain difference on the anterior surface, and that is translating on to the DF. So there are two aspects of this. One is, remember, if it's a normal topography, but the pachymetry is on the lower side, some of these parameters invariably would be driven into yellow or red. If there are changes in the anterior surface of the cornea, chronic inflammatory condition, dry eyes, there would be aspects which can impact a DF. So it's important to understand that each one of these parameters can actually get impacted by other factors in the imaging, and that can actually mislead us. So if we looked at this and just directly jump to the bad D value, it is 2.7, which is above 2.6, and that is obviously which is abnormal, but I would still not call this an abnormal topography. So that is something which we need to remember and understand, and that is where we need to move into understanding another set of indices. And what I wanted to talk about is that people who have Pentacam here, it's important to look at something which is known as the Topometric Kc Staging. Now remember, any tool or any topographer is designed such that we are trying to distinguish or trying to, sieve out the suspicious cases from the normals. That is our primary aim of refractive screening, so that we select appropriate cases and, it undergoes surgery. Or we look at a set of cases where, it's able to detect whether it is a form first keratoconus quite accurately. There is no, discrepancy, or there is no ambiguity when you're talking about full-fledged keratoconus, but it's the cases which in between which are doubtful. That is where the accuracy of a topographer actually comes into the play, and that is what is important for us to remember. When you're looking at the Topometric Kc Staging, there are a lot of parameters, we're looking at the index of surface variance, vertical asymmetry, horizontal asymmetry, height decentration. The main fact or the factor which is actually important in this is the fact that these are the indices which are based on something known as asymmetry. So what is asymmetry is whether it is inferior-superior asymmetry or asymmetry between two quadrants or zones. These are the earliest changes which are actually detected earlier than changes if you look at bad D. So the take home is, you are obviously looking at bad D. Don't base your judgments based on bad D in the pentacam. Always go ahead. If you have the tool, it would be good to just not look at the printout, go sit at the machine, look at these indices and parameters. And the topometric Kc staging is in fact, the parameters in that map, which is, asymmetry indices, whether it's ISV, IVA, IHA, in fact are more sensitive to detect normals versus suspects versus just looking at bad D. So that is what is important in these cases. For cirrus, I think you will have a lot of indices and parameters. You have something, known as the symmetry indices, which is symmetry index front, symmetry index back. You have something which is based on, the height from the best fit toric sphere. You get something known as the keratoconus vertex front and back. You also have something known as root mean square, which is basically a deviation or how regular the corneal surface is when you're looking at the best fit toric sphere. So for users of cirrus, basically every company packages or looks at the same thing. All right, and there are analogous indices in pentacam which correlate well with certain indices in cirrus, which correlates with certain indices in Galilee, and that unless we understand the principle, it is difficult to really figure out as to why there are so many parameters. So when you're looking at parameters in the cirrus per se, remember I spoke about IVA, IHD, and IHA. Analogous to that is the symmetry indices, which is SIF and SIB. So it is obviously difficult to remember the cutoffs, and what as cirrus users we normally do is go to the last end and just go to the diagnosis, whether it is suspicious, whether it is keratoconus. But we don't go into what exactly each one of these parameters are. So the case which I showed, there were some parameters which are telling me that it is Kc, some parameters which are telling me that it is normal, some parameters which are telling me that it is suspect. What do I look at? And what do I compare? You might have a patient who's coming with you with a pentacam readout, but you have a cirrus at your center. So you need to understand and correlate. So the take home here is always look for asymmetry indices with any topographer to compare whether it is normal or suspicious. So in the pentacam, I spoke about IVA, IHA, IHD. The same indices in the cirrus is something which is known as the symmetry index front and symmetry index back. I'll come to it a little later. The same, how many of you have a Galilee by any chance? Anybody has a Galilee topographer? Okay, that is, among the topographers, the one who have released prevalence. But even here, there are parameters which look at symmetry. Okay, so SAI stands for the symmetry, astigmatism index. There is something known as the opposite sector index. There's something known as the center surround index, and it gives you an overall score which is known as the keratoconus probability. So I spoke about multiple parameters. Take home from the pentacam is, remember, these are the parameters which in fact are more sensitive, in fact are even more specific than the other parameters which I spoke about in bad D. I'll be coming to a study which we did a little later on artificial intelligence. The same thing goes on screening indices when you're looking at cirrus as well. Remember symmetry index front and symmetry index back. So the main concept is you're looking at two zones on the anterior tangential curvature map, and you're basically trying to compare or look at the asymmetry between these two zones, whether it is the inferior superior asymmetry or the superior inferior asymmetry. It's one and the same, but you're comparing two zones, and earlier detection of this is in fact more sensitive than any of the parameters. So don't just look at the class. Okay, even if this is normal, symmetry index front and back can actually be abnormal, right? So that is telling me that there is something which is still suspicious. Do not just look at the last reading or recording which you get, and that is something which is important to remember. Now, keratoconus vertex front and back, I spoke about it. It's basically the point of maximal elevation of the anterior and the posterior corneal surface. And cirrus gives a very good tool which is inclusive of something known as aberrations. So the Biachi-Calossi-Versace index gives and includes that as well. Now, finally, what all of us are used to in cirrus users is we go to the last map, keratoconus summary map, which gives us an idea as to whether the patient is in which bracket, whether it is normal, whether it is suspicious, or whether it is, a frank keratoconus, and that is something which is important to remember. Remember, keratoconus screening cutoffs are based on the factors which I spoke about. The key takeaway is that each of these factors may actually differ, and therefore understanding each one of this is something which is very important. When you're looking at Galilee per se, I would go directly to what parameters I wanted to speak about is these parameters, which is known as the center surround index, opposite sector index. I spoke about analogous indices. So the basic topographer, what they do is they look at asymmetry. All of this is again on asymmetry between two zones, and therefore these are in fact very sensitive tools and indicators. We also have done studies on how do we know which which one of these topographers are actually, what are the indices which correlate, and we actually, published this where we looked at the screening indices and their diagnostic ability to detect normals from, ectatic. Remember certain parameters when you're looking at for pentacam users, it is the Topometric Kc Staging map, the ISV, IHA, and the IHD. For Cirrus users, or for Galilei users, remember, the DSI, or the OSI. These are basically, again, asymmetry indices of the highest sensitivity and the specificity. For Cirrus users, remember, I spoke about something known as symmetry index front and back, and that is also something which is important for you to remember. So I'll be ending off by saying that we also looked at, trying to correlate and, build this into an AI model. Remember, all of these indices is difficult to remember, and what we've published is, in fact, one of the first papers, it is the first paper in the world which has predicted how progressors behave, what are the indices which are picked up, and believe me, BAD-D was not one of the parameter picked up. I spoke about ISV, IHA, and IHD, and that in fact was, the parameters which were in the topmost rank, if you can see, much higher than BAD-D. BAD-D in fact was 9th or 10th down. So remember, indices, there are a lot of indices, a lot of parameters. What we actually look at is something which is very important. Remember, do not base your judgment based on color coding, based on the set indices. Look at asymmetry indices, and it is always good, even if you have a Cirrus, to look at which one of the parameters in pentacam correlate well. So ISV, IHA, and IVA correlate well with the parameters in, the Galilei, which is the DSI and the OSI, and it correlates well with the symmetry index front and the Cirrus. So that is something which is important to remember. I am ending my talk here, and we'll proceed with it. So the challenge is that, remember, tomographical changes are, whenever it starts off, it can actually be at an advanced stage. And true disease would be defined by a structural weakening or a structural or a focal weakening in the structure. So that is where the concept of biomechanics came into the being. Do any of you have any biomechanical devices or tools in your armamentarium? No? Okay. So what we normally use, a little brief before I call on the next speaker, is the Corvus. Okay. So that Corvus, like the Pentacam, is also a Scheimpflug device. It is a high-resolution Scheimpflug device, and it actually in real time looks at the deformation and looks at how much the cornea basically deforms when you put a puff of air. Now, majority of the parameters which you look at when you're talking about biomechanics is something known as the dynamic corneal response parameters. So the dynamic corneal response parameters look at these various factors, the deformation at the first applanation, deformation at the second applanation, and the distance between both, which is known as the peak distance. This is part of the next talk, so we can, and remembering that, there are various screening parameters, what I wanted to go ahead, the reason why I'm giving you a brief is so you'll be able to understand the next talk better, is like BAD-D. You remember BAD-D, I spoke about DF, DB, DT, and DA. The same thing holds true even in the Corvus biomechanical index, where they have an overall index like a BAD-D, which is quite sensitive in detecting early ectasias, where anything which is less than 0.5, you can consider as normal. And it has individual parameters, whether it is the deformation amplitude ratio, the stiffness parameters, the integrated radius. So that is something which is important for you to remember. Now, how do you combine this? The purely biomechanical index which we see is the Corvus biomechanical index. BAD-D, as we know, is from the Pentacam. A combination of the BAD-D and the CBI is what we know as the TBI. Now, what our next speaker will be speaking today, I now invite Dr. Divya. She is a fellow with us at Narayan Nethralaya, done extensive work on imaging and in biomechanics. She will be taking us through certain case scenarios, an algorithm, and how we actually can play around with biomechanics and how biomechanics can help us, translate into clinics. Now, it's not that you need to have the biomechanical tool in your clinic. Remember that, there are obviously limitations if you are a group practitioner or a private practitioner. The ultimate aim would finally be to, look at parameters or corroborate indices. So there would be certain parameters in the pentacam which correlate well with biomechanics. That is in fact the ultimate tool, aim of looking at indices or playing around with these topographers and biomechanical devices. So over to you, Divya. You can start your talk on biomechanics.
Thank you, sir.